welcome everyone. To the second series of Asian EUS webinar focused on interventional EUS. So I think Lawrence, the president of the Asian EUS group, will start with some welcoming words.
Okay, good morning to everyone. It's a pleasure for me to be here representing the Asian EUS group. What you call the background for Asian EUS group, that's our logo.
That's nice.
Anthony has actually asked me to just briefly introduce Asian EUS group because I think this is one of those webinars which the group has been organizing since the outbreak of COVID-19. So I think it's also given us an opportunity to widen our scope of the activities, educational activities to a more international audience, as well as inviting more international faculty. So I think since some of you may not know of this particular group, so I thought I might just introduce you to this group. Maybe I can actually share the screen.
Okay.
Okay. Okay, so I think, I hope everyone can see the screen here. Can we?
Yep. Okay,
good. So I think the group essentially is, obviously, I think comprises countries from all over Asia because it was started quite a number of years ago as a group which is with the mission of trying to increase the adoption of EUS through training. And over the years, I think we have gradually expanded the membership to many countries in Asia. And we also succeeded in differentiating ourselves, chiefly using this sort of matching method, meaning that we will try to match trainers with trainees, and then meetings and using this particular model of ours, which is dominantly hands-on. Obviously, I think since the outbreak, the hands-on has not been able to be done. So I think in this particular circumstances, I think some of the members have taken the initiatives, like Anthony, as also Vinay last month, to organize webinars instead. I think over the years, certainly we have done quite a number of works, organizing many workshops, such as those in this particular slide, in many different countries. And at the same time, we also organize train-the-trainers courses, mostly catering for more experienced EUS practitioners so that they can advance to become trainers and then organize courses in their own countries. And of late, with the advent of interventional workshops, such as this particular one, we have also started venturing into organizing interventional workshops. I think the strength of all this, how we could manage to do all this, is because the members have also taken the initiatives to come up with their own training models. The different models, hopefully, Anthony can introduce some of those models in his particular webinar today. And over the last, it's quite unusual in the sense that we started off with sort of basic workshops and so forth. Then we advanced to organizing bigger scale congresses such as the Asian EUS Congress. I think the first one was organized in Korea in 2015, and it just happened to coincide with MERS. And now we are actually moving on to the era of the COVID-19. So it seems that we can't escape from some sort of outbreaks. Some of the times it is our evolution of the Asian EUS group. So finally, I think besides organizing educational activities, we have also been quite active in coming up with so-called consensus guidelines. And that's also part and parcel of the mission to train EUS practitioners, especially in this new area where I think there's still no good so-called consensus regarding many of the interventional procedures we do. So that's when I think Anthony, quite a number of years ago, took the leadership to come up with a group which subsequently produced the consensus guidelines, which I think he'll share with you again in this webinar. So finally, I think obviously, I think we have been quite busy dealing with this virus since the beginning of this year. And because of that reason, I think we took upon ourselves to say that we should not stop our educational activities. And that's where we are resorting to technology. And with that, of course, I think we can now also expand our reach to a more international audience and faculty. Hopefully, I think this will actually continue even after the outbreak, because I think we found this extremely useful. So finally, I think I'd like to congratulate Anthony for organizing this particular course. I'm sure all of you will enjoy this course and then learn a lot today. Okay, so thank you very much.
Okay, thank you, Lawrence. So as you can see in the program, we have a world-class faculty list. Thanks to the beauty of Zoom and webinar, we can invite everyone from the world. Apart from faculties, we also have a lot of participants. So the statistics from Flora show me that up to just now, we have 903 registrations. So this is quite amazing. And from a total of 60 countries around the world. The highest number is from Japan, 182 registrations. Colombia, also 128. India, around 80. Hong Kong, 50. And then so on. So we have people from Argentina, Australia, Brazil, Italy, Iraq. So Saudi Arabia, Pakistan, so everywhere around the world. So it's very amazing, as well as USA. So thank you very much all for your hard work. I'm sure our participants will benefit a lot from this webinar. Also, thank you to our sponsors. This time we are trying something new. So during break and lunchtime, our sponsors will have around 20 minutes each, and they can be presenting something about their products or tell us something new. So during break time, please also check out the webinar and see what they want to tell us. So without further ado, I'd like to introduce our faculties first. So we have a list of faculties presenting throughout the day. So I'm going to go through them one by one. So first off will be Dr. Shannon Chan. She's already at the webinar. And then she is from our unit. She is an uprising star in interventional EUS. And also she is recently published some very important papers, including a paper in gastro that was published on concerning the EGD, confirming it as a aerosol generating procedure. Afterwards, we'll have Isayama Sensei. He'll be talking to us about the techniques and outcomes on EUS rendezvous. Dorian Park, again, a very prominent leader in EUS-guided biliary drainage. He led many earlier studies on issues around CDS, HGS, and also did a very important randomized trial comparing eusbd versus ERCP. Vinay, I think we all know him. He's a very prominent world leader in eusbd. He'll be talking to us on antegrade stenting. Michel Kahale, another old friend. He is speaking from USA. Again, he not only in eusbd, but he is also performed many pioneer studies on US various EU interventions. Afterwards, we'll have Mark Giovannini. Again, we all know him. He did the first eusbd back in 2001. So he'll be talking to us on US versus PTBD. Kida Sensei, again, a very prominent person in Asian US group. He's been holding annual train-the-trainer course in the Kitasano University. Afterwards, we will have Paolo. He is from Italy, relatively new friend, but he is also performing a lot of US interventions, and he is also a participant in my trial comparing US biliary drainage versus ERCP. Itoi Sensei, again, I don't need to introduce him too much. I think everyone in the world, around the world, knows him very well. He'll be talking about anti-grade stone extraction, followed by Manolo Perez Miranda. Again, everyone knows him. He'll be talking about EUS-guided enterostomy for accessing products. And last but not least, Ogura Sensei. So he's a very prominent US interventional endosonographer. He told me he's done over 1,000 US XGS. So he'll be telling us about his useful tips in eusbd, as well as how we can use eusbd as a means of carrying out biliary interventions. So without further ado, I'd like to start with Dr. Shannon Chan, and she'll be discussing an overview on eusbd techniques and the Asian US guidelines on US biliary drainage. Shannon, thank you.
Okay, so can everyone see the PowerPoints?
Yep.
Okay, good morning. So thank you for inviting me as the first speaker to speak in before all of these giants. I'm very humble and very honored to be here. So I'll just give a very, very brief overview of all the EUS biliary drainage techniques and the consensus guidelines that Lauren just mentioned, developed by the AEG 2 years ago. So there are lots of different kinds of EUS-guided biliary drainage procedures. Here you can see this is a choledochoduodenostomy with a fully covered duodenal stent. Beneath you see a CDS done with a hot axios and with a double pigtail inserted, and the hot axios is actually here. And this is obviously an HGS that is done with a geobore. And this is gallbladder drainage with spaxes. And this on the right side is an anti-grade stone extraction. And then on the right lower corner is an anti-grade metal stenting. So all of these actually have different indications, different risks, and different techniques. So which one to use and when? So 2 years ago, the AEG group published this consensus guidelines on the optimal management of interventional EUS procedures. And in it specifically has a consensus statement on the optimal management of EUS guided biliary drainage. So we will go through them one by one. There are 15 points. So first, the indications of the procedure. So first, EUS biliary drainage is recommended as a procedure of choice for biliary drainage in patients who failed ERCP if the expertise is available. At that time, there were 3 randomized controlled trials published, and you can see that all of them are very small sample-sized studies. So the first study, actually 8 years ago, published by Professor Artefon, including only 13 versus 12 patients comparing EUS and at that time PTBD as the salvage procedure of failed ERCP. And you see that the technical success and the clinical success rates are actually very similar. All of them is 100%, and there is no difference in the adverse events. The second study then published was from Professor Lee with a slightly larger sample size, also with similar technical success and clinical success. However, there is more adverse events with the PTBD, mainly tube-related complications such as tube dislodgement, tube blockage, etc. However, the EUS group has a more, and the PTBD also has some more reinterventions required due to the tube-related complications. The third study then tried to compare EUS with the surgical GJ, also with a relatively small sample size, showing similar technical and clinical success, and there was no difference in the adverse events. So then there were subsequently 2 meta-analyses published in this regard with the EUS guided biliary drainage. So basically, the conclusion is that the technical and clinical success rates is very high, more than 95%. And the cumulative adverse events is a bit heterogeneous. So it ranges from around 13% to 20%, even in expert centers. In this second comparison between EUS-guided biliary drainage and PTBD, this is a randomized controlled trial published by Professor Lee and Professor Kim in the career group. So the primary outcome of this study was the technical success of the EUS-guided biliary drainage. This is a non-inferiority study designed with a margin of 15%. And you can see here is the results. So in terms of the technical success rate, EUS-guided biliary drainage was proved to be non-inferior to that of the PTBD. And the clinical success rate is also similar in both groups. The adverse events, again, PTBD is more, mainly due to the tube-related complications. And also the PTBD group has more reintervention rate together with a longer hospital stay. So all in all, these studies points more towards EUS-guided biliary drainage in case of failed ERCP, but these are very small randomized controlled trials that we have at this moment. So the second statement of the consensus guidelines is that eusbd is an alternative procedure to obtain biliary drainage in patients with altered postoperative anatomy or duodenal stenosis precluding ERCP if the expertise is available. So the success rate of these patients with altered anatomy if ERCP is actually not possible up to 40% of the case. And EUS biliary drainage is a good alternative in such situation as the bile duct cannot be accessed from the stomach. However, only small retrospective comparison studies are available. So in this comparative study published by Moen 4 years ago, comparing EUS biliary drainage with enteroscopy-assisted ERCP for patients with altered anatomy. So you can see in the EUS-BD group, majority of the cases are HDS cases. And for the enteroscopy group, the technique used was mainly the short type double balloon ERCP. So you see that the procedure for enteroscopy-assisted ERCP, it has a longer procedure as expected. However, the hospital stay is EUS group more, and the technical success rate is also EUS biliary drainage, which is higher. Clinical success also is a win for the EUS guided biliary drainage. So this is the only comparative study that is available at that time. Comparing these two techniques. So then the conclusion is that if you have the expertise of doing EUS-guided biliary drainage, it is a preferred technique over enteroscopy-assisted ERCP for patients with altered anatomy. In this study, there was also a univariate analysis and a multivariate analysis, and this showed that EUS-BD is an independent factor to the success of biliary drainage, and that, however, it is also related to more adverse events. So the availability of expertise is important in these situations. So then the third statement is that in patients with distal common bile duct obstruction, the transduodenal and transhepatic approaches for EUS-BD are used. So they try to give standard nomenclature to all these procedures, because at that time, people call different procedures different things. So they try to have a standard approach of referring to the specific procedures. So EUS-BD, either gain access with the EUS to assist the ERCP. So this is the EUS-guided rendezvous ERCP, or you do a direct drainage with the EUS-guided biliary drainage, including the antegrade stenting, or the transmural drainage, which can be divided into choledochoduodenostomy, also called the CDS, or the hepatogastrostomy, also called the HGS. So for EUS-guided rendezvous ERCP, basically it is to achieve access with a guide wire through the papilla to help with the ERCP. So there are usually two approaches. So first approach, you put the scope in the duodenum, reduce the scope, so then the scope points downwards towards the papilla, poke in the guide wire and pass it through the papilla, and then exchange to the ERCP for biliary drainage. Or in cases where this is not possible, the second approach is to to put the scope in the duodenum in a long lip position, but this is less advantageous because then you see that the guide wire points upwards where your target destination is actually downwards towards the papilla. But sometimes due to the anatomy, this may be the only way that you can do it. So using a curved tip guide wire would be helpful. Or some people would prefer using inserting the guide wire through the left lobe of the liver, through the IHG on the left side. Then the direction towards the papilla would be more advantageous. So basically, these techniques have the same efficacy. Either you poke it through the duodenum or through the stomach, as long as the ducts are sufficiently dilated. So we're coming back to this. So we have seen this slide before. So all these techniques, which one is preferred, which one is better? So this is a video showing the CDS procedure with the axios. So this is a patient with malignant unresectable pancreatic cancer. So the CBD measured 15 millimeters. So we used a 19 gauge needle to poke through the CBD, confirmed with bowel aspiration, and the guide wire passed up to the IHD. And subsequently, this is the hot axios. So you can see that the electrocautery that is going through the common bowel duct, and this is the deploying of the distal flange of the axios. And subsequently, at that time, you were still using the black mark technique. The proximal flange is then deployed. So then this is also a short video on EUS-guided antegrade stenting. I'm sure there is a lecture in the morning about this, which will go more into the details, but this is just a brief video on how it is done. So first we screen the left lobe of the liver for segment 3 ducts, and then insert the needle, confirm with bowel aspiration, do a cholangiogram, pass through the guide wire. So in this case, there was a little bit of difficulty passing through the guide wire through the hilar where there was a stricture. So subsequently, we used the 6 French cystotome, which is currently passing through the liver into the left ducts, to help guide the direction of the guide wire and to support the guide wire through the stricture. So you see the cystotome is going through the left IHD and subsequently passing through, passing the guide wire through the stricture. So once the guide wire is down, then the subsequent steps would be relatively easy because it is more similar to ERCP deploying the stent. So once a guide wire is through, the cystotome is followed through with contrast confirming the position of the ampulla, allowing us to measure the length of the metal stent that is required. And subsequently, a metal stent is passed through. Okay. So there are studies trying to compare the efficacy of CDS versus an HGS. This is a study also published by Moen 4 years ago, comparing these two methods. So you can see that both procedures have very similar technical and clinical success rates. The procedure time is actually also similar. The length of stay, however, is longer for the HGS group. And in terms of adverse events and the need for stent exchange during follow-up, they are similar. And in this particular study, they tried to measure using a Kaplan-Meier plot to confirm the stent patency after CDS and HGS. This dotted line is the stent patency at 1 year. And you can see, although on the graph, it's very obvious that they are, CDS has a higher stent patency, but this did not reach statistical significance. In this multivariate analysis, which we will mention this table again, it proves that the use of a massive stent and the use of non-coaxial electrocautery is associated with adverse events in these procedures. In another study comparing HGS and CDS, it also showed very similar technical success, clinical success, procedure times, and adverse events. So all in all, with the available evidence, the conclusion is in patients with distal common bowel duct obstruction, both procedures can be performed. The choice of the procedure is not clear, but depends on a combination of factors, including the technical expertise, the stent patency rate, the risk of adverse events, and also anatomical factors such as the presence of dilated bowel duct or duodenal stenosis or altered anatomy. So the fourth guideline is that a transhepatic approach to EUSBD is recommended for Hylar blocks. So for patients with a Hylar stricture, transduodenal stent placement is likely to be more challenging, and therefore the transhepatic approach is preferred. Drainage can be obtained either with antegrade stenting or with an HGS. And it is to be careful that there is a risk of cholangitis when contrast is injected into undrained segments. So care should be taken to avoid excessive contrast injection. So the fifth point is more or less a pre-drainage evaluation, whether MRCP or CT is needed before the drainage procedures. So the recommendation then is if the patient has a Hylar stricture or a Hylar obstruction, a pre-procedure roadmap is required either with an MRCP or a CT scan. The recommendation is actually extrapolated from that of an ERCP. However, for patients with a distal bowel duct obstruction, an ultrasound and a CT scan would be sufficient for these low CBD obstructions. So the sixth statement then is more or less of a common sense. So antibiotic prophylaxis is recommended before these drainage procedures. And this is also extrapolated from that of an ERCP from this Cochrane review that prophylactic antibiotics reduces bacteremia and prevents cholangitis and septicemia in ERCP. So for EUSBD, it's a very similar logic that we give broad spectrum antibiotics. So then this more is in the guidelines onto the procedure considerations of what needles or what guide wires you should use. So basically a 19 gauge FNA needle is recommended for duct puncture. And the reason is because the 19 gauge allows the passage of both an 0.35 or an 0.25 inch guide wire. And for smaller size needles, smaller guide wires like an 0.18 is needed. And sometimes it will be very difficult to manipulate through and will not be strong enough to support the stent to pass through. And the use of a flexible nitinol needle may improve the maneuverability of such positions. And for guide wires, either 0.35 or an 0.25 inch guide wire with a floppy tip should be used to negotiate through the ducts. So the use of a guide wire varies a lot in different centers, and it appears that both all sizes and whether you use a Terumo or VisiGlide, it depends on the preference of the center. So some people actually, like Dr. Venadia, likes to use a 250 Terumo to manipulate through the guide wire and with subsequent exchange. So which guide wire you use, basically, it depends on the center's preference. In terms of catheters, balloons, and cystotomes, these are recommended for the use of tract dilatation, and that the tract dilatation with a pre-cut papillotome is not recommended. And this is based on this study published by Professor Park a few years back, stating in a multivariate analysis, comparing EUSBD with after failed ERCP. So they identified that needle knife is one of the independent risk factors for adverse events for EUS-guided biliary drainage. So the recommendation is that pre-cut papillotome is not recommended for tract dilatation. A 6 French cystotome is favored as it is fast and efficient, and 5 French stiff catheters and 4 millimeter dilating balloons may be used if a cystotome is not available. So there are also some one-step devices that is currently available now. I'm sure all of you is familiar with the hot Axios, the hot Spexis, and also there was also a study in the Korea group on this do stent, which is a one-step metal stent for HGS. So these one-step devices avoid the need for repeated instrumentational changes and reduce procedure time. So these can be used in appropriate situations. As for stenting, fully or partially covered metal stents are recommended for transluminal stenting. Uncovered stents, on the other hand, can be used for antegrade transpapillary stenting. So covered stents are preferred for transluminal procedures to prevent bile leak, as for example in the case of an HGS. And for uncovered stents may be used for antegrade EUS stenting. Lumen opposing stents, as shown in the last slide, such as the Axios and Spexis, they are good for anchoring, so good for gallbladder drainages and pseudocyst, but there is limited data available for the use of these stents except in CDS. So the 11th recommendation is that the use of a metal stent is recommended over plastic stents for EUSBD to reduce the risk of leak. So coming back to this study that we have discussed, published by Moen, comparing the efficacy of EUSBD and ERCP. And so here in the multivariate analysis, he was able to show that the use of a plastic stent and the use of a non-coaxial electrocautery is independent risk factor for adverse events. So, and in another study published by Gupta in 2014, it also showed there is a significantly higher incidence of cholangitis in patients with plastic stents. However, there is no difference in bile leak. So overall, the recommendation is if you have a metal stent available for the use of an EUSBD, it is recommended over plastic stents. So then comes to the management of complications. So multidisciplinary support, including interventional radiologists, surgeons, anesthetists, is required to prevent and manage complications in centers performing EUSBD. So EUSBD may give rise to severe adverse events like perforations, bile leaks, and bleeding. It is advisable that surgical and interventional radiology support be always available in centers performing these complicated procedures. So here I show one complication that happened a few years ago. So I was the one doing the procedure. So this is an HGS that was planned. So this patient had a distal bile duct obstruction. So you can see here that I was deploying the stent. At that time, the deploy and channel technique was still not available. So I was trying to pull the scope back to deploy the stent. So you see here in the luminal view, initially everything was going fine, but then I did one thing wrong, is that I pushed the scope into the stomach instead of pulling it into the esophagus to deploy the stent. So as I was pushing the stent, this whole stent was actually pushed out towards the peritoneal cavity. And this is what I saw after I deployed the stent. So this is a guide wire. And this is the entrance site from the stomach. So luckily, the guide wire is still in situ. So with the guide wire in situ, you can actually salvage the procedure with the insertion of another metal stent. At this point, I also did another thing wrong, is that the scope was actually, the direction was not actually facing that of a stent. So as you see, as I pushed in the metal stent, the guide wire was actually pushed away. The guide wire with the previous metal stent you can see here is actually pushed away, and I was having a lot of difficulty pushing it in. So at the end, there was a nightmare after another nightmare. So the guide wire was also dislodged. So what happened subsequently was then, of course, I consulted my senior, which is Theo. And so what he did was he closed the entrance site of the gastric opening with the previous opening site with over the scope clip. So first deal with gastric perforation that was induced for during the procedure. So second is to deal with the bowel duct. So there was a stent that was deployed, one end in the liver and the other actually in the peritoneal cavity. So the EUS scope was inserted and trying to find the stent, and luckily the stent was actually in a favorable position, and we were able to puncture the previous stent, pass in another guide wire. And insert another fully covered stent to bridge the leak. So you can see the scope position this time is much better. The direction of the metal stent is actually facing the previous metal stent. So the deploy of these, this stent is in a more favorable position. This patient subsequently had collection, intra-abdominal collection, which luckily I'm a surgeon, that we went in and drained the collection. It was quite stormy after the, even with this salvage, but the stent that was inserted subsequently bridged the leak, and we only had to deal with the collection subsequently. So again, this illustrates the importance of the subsequent recommendations in competency and training, is that these procedures should only be done in expert centers with facilities and expertise in EUS, ERCP, and PTBD. And for example, in the case just now, if you are not able to salvage it with EUS means, you can always put in a PTBD, drain the collection, close the perforation site with endoscopic clipping. And the 14th statement is that eusbd should only commence in endoscopists who are experienced in FNA, wire manipulation, and biliary stent placement, and that PIG or ex vivo model are suitable hands-on training for EUS BD. So here, I would like to wish everyone stay healthy, keep calm, and wear a mask and continue to do EUS. Thank you.
Thank you very much, Shannon. So before we move on, I would like to introduce the two moderators for this session. So Lawrence,
Yes.
as Raymond, will be moderating this session. And before the next lecture, I also would like to make a mention, to thank Professor Lazaro, because he's been very kind to set up a real-time translation of this workshop, entire workshop, into Spanish. Lazaro, maybe you can share the Spanish link on the chat screen. So I know it's late in Colombia, but I think we have over 100 people watching in YouTube the real-time Spanish translation of this workshop. So thank you, Lazaro.
Shannon, excellent conference.
Thank you, thank you.
I'd like to.
So yeah, so I'll hand this session to Lawrence and Raymond, and then you guys can introduce the next lecture, as well as answer some of the questions.
So I think maybe I'll leave Raymond to introduce the next speaker, but I have a question here from one of the, I think, our audience. Okay, maybe Shannon can answer this question. I'm not sure whether you're reading it. It's in the question and answer. It reads, in hepatic bowel drains, if you do not use lamps, to use a double pigtail to fix the self-expanding stent and decrease the risks of migration. Say you use normal metal stents, do you use a plastic stent, double pigtail plastic stent to fix the stent so that it doesn't migrate? That's the question, Shannon.
Okay, thank you very much for your question. If you're talking about HGS, for us, we use a partially covered stent. So the uncovered portion is actually within the bowel duct, and the covered portion then bridges the bridges the liver and the stomach with a covered portion to prevent bile leak. So basically the uncovered portion prevents stent migration. So for us, we do not routinely insert a double pigtail to prevent stent migration. I know that for some centers, if they use a fully covered stent, they insert a double pigtail to prevent migration. There are also other choices of metal stents, including some metal stents that have these flanges on the proximal side to prevent stent migration. So I guess all in all, we're trying to do something to prevent stent migration, which is one of the most unwanted complications from an HGS. So you can either choose an appropriate metal stent, and if you don't, a double pigtail plastic stent is definitely a good way to prevent these stents from migrating.
Just one more question before we move on to the next speaker. This question, I'm not sure whether you're reading it. Is it difficult to use a cystosome on VC glide? And many times it does not work very well. So I think in this particular person, Ravindra, saying that their experience is to use the Roma.
Oh, actually, I also have, I also use VisiGlide together with 6 French cystotome, and most of the time it works well. Sometimes I've been in a few situations where the cystotome doesn't go through. My feeling is it's not the problem of the guide wire. It's more problem with the contact of the cystotome and the setting of the cystotome itself. Because for us, we use our cystotomes. So sometimes for us, that is a major problem. So if I encounter a problem, I change a new cystotome. I don't really have a feeling that it is related to the guide wire. Lawrence, do you have any suggestion on that?
No, I think the VC glide is actually quite good.
Yes.
Actually, may I supplement? Sometimes the traction provided by the nurse assistant is actually very important, because sometimes the scoop position could be more angulated or have some buckling on the wire. Then passage of the cystotome could be difficult, but with some appropriate traction by the nurses, so that may help you actually.
Okay, good. So I think we are sort of into the slot of the second speaker now. So maybe I'll leave Raymond to introduce the second speaker.
Okay.
I have the program in front of you.
Yes. So our next speaker is Professor Isayama. So Isayama Sensei is a very renowned interventional endoscopist, doing ERCP in altered anatomy patients, so expert in EUS. So he needs no further introduction. Today, he's going to share with us his experience on the techniques and outcomes of EUS rendezvous. So thank you.
Okay, thank you very much. Can you hear me? And now I want to share the, now I'm trying to share the my screen. Can you see now?
Yes, we can see.
But I cannot see. Okay. Okay. Can you see now? It's okay? It's okay. So I want to today's my topic is EUS rendezvous. Thank you very much, Anthony, to give me a very good chance. And it is very strange to see you through the screen to you. So EUS rendezvous. So it is a very effective procedure, and it is firstly published by Professor Freeman's group. Previously, we performed rendezvous technique using the transhepatic route, percutaneous route. And we are familiar with this procedure, but with EUS, it is a brand new, it was a brand new procedure. So this slide shows the Japanese eusbd guidelines recently published. So EUS rendezvous, you can see here and here. So difficult biliary access. So patient with accessible papilla So we can perform the both rendezvous techniques and also EUS-BD, so CDS, HGS, or integrated stenting. So it is a more simple algorithms. So for the ERCP, accessible papilla, so EUS rendezvous. Sometimes rendezvous techniques failed to pass the stricture if the patient with the stricture. So at that time that we can perform the EUS, CDS, or HGS. But without a stricture, so maybe we should try again and again. So there are many steps of the EUS rendezvous. So firstly, we should select a scope position. So transgastric or transduodenal, previously mentioned by Shannon. So and puncture the bile duct with recently we use a 90 gauge needle, and we prefer the user busy glide. And the injection of the contrast medium, guide wire insertion, and this is a very difficult step. Pass the papilla by using the guide wire manipulation. After the successful guide wire insertion into the duodenum, so we should exchange the scope. So echo endoscope to the duodenal scope, so standard ERCP scope. And the final step is the cannulation. There are many steps and a very time-consuming procedure. So this slide shows the scope positions in EUS rendezvous. So this one is a transduodenal short position and a long position. This is a transgastric scope position. So there are some differences, these scope positions. So I prefer this one, so puncture from the D2. So also previously mentioned by Professor Shannon. This is our previous review about EUS rendezvous. So puncture success is very good, but total rendezvous success is not so high. Only Dr. Diaz's article is very high. Maybe he's a magician using the hydrophobic guide wire, and he has a very good NAS. Now maybe this slide shows the difficulty in the guide wire manipulation. And comparing the TD, transduodenum, and the transgastric, transduodenum is better. So we should select transduodenal rather than the transgastric to get a success. I want to show some videos. This is a transgastric. So similar with EUS HGS. So puncture the left hepatic duct and using the guide wire. Relatively difficult to pass a stricture with a guide wire and papilla. And in duodenum, after the scope exchange, catch the guide wire and pulling back. And finally, cannulation over the guide wire. So it is an old style rendezvous technique, transgastric. This is a transduodenal short position. So puncture direction is very good. So guide wire insertion and tour to the papilla very smoothly. And also other beneficial is a very short distance between puncture point to the papilla. So then very easily to pass papilla by this technique. So I think the puncture direction is very, very important to get a success, to pass a papilla. So from this point, TDS is a very good procedure, I think. So next one is a transduodenal long position. So puncture is relatively easier. So because of the larger bile duct, CBD. So, but sometimes difficult to manipulate guide wire toward to the papilla. So sometimes a guide wire go into the hepatic portion. So then I think the scope angulation and of course, so elevator angulation is very important to get a good direction toward to the papilla. So this is a TDL, long position. So this is a summary of the these three techniques. My junior doctor Saburo Matsubara made this slide. So puncture site, TDS, D2, TDL, D1, TZ, stomach. And it is very important point, scope stability. TDS is a very good procedure, but sometimes scope stability is poor. At that time, so we should change the scope position, TDS to the TDL or TZ. And also a very important point is puncture easiness. And guide wire manipulation easiness is the most important point, I think. And from these factors, I think the TDS is first line. So good puncture direction and a short distance to the papilla. And this is our EUS rendezvous algorithm. So first line is the TDS and second line is the TDL. Sometimes we should select a transgastric route. And this is a special route, TDL for the left eusbd. It is a very, very rare case. So Dr. Iwashita published a similar algorithm. So first line, second line approaches. And from his article, so look, guide wire manipulation is very poor in a D1 puncture and a stomach puncture. So D2 puncture is best. So it is depend on the puncture direction, I think. So and also it is a very good point to get a success in the transduodenal long position. So look, this is a very good puncture direction with a very good angulation with scope and also elevator up. So both guide scope angulation and elevator angulation, we can get a very good direction. It is one of the tips to make a guide wire manipulation easier. Other tip is using the hydrophic guide wire. So I think it is not only a guide wire by Dr. Binay, he's a magician. And using the hydrophic guide wire, so it is easier than the other type of the guide wire. And if we use this type of the guide wire, we use a long guide wire, but they use a very short one. So, and they use a special technique to exchange the guide wire, water injection method. It is sometimes very risky to lose the guide wire. Other tips is also published by Dr. Iwashita using the catheter. They called this technique hybrid rendezvous. So they use a very thin tip catheter, but I think that it is also we can use a standard ERCP catheter. So insertion of the catheter, guide wire manipulation easier. So then I think that this is the second step. So initially we manipulate the guide wire through the needle. But if we fail to pass the papilla, so we insert initially withdraw the needle and the insertion of the catheter and manipulation again. Sometimes we can get success via better guide wire manipulation. After the guide wire insertion into the papilla, into the duodenum, there are some type of the method of the cannulation over the wire and along the wire and the hitch and ride technique. So it is very important. Guide wire grasping and the pulling back technique. It is a very time consuming and risk of the guide wire loss step. Over the wire required this step. But after the guide wire pulling back, cannulation is very easy. Along the wire, can skip the this time-consuming part, and the cannulation method is very simple, but success rate is very low, because basically difficult cannulation, difficult biliary cannulation case, and also a risk of PD cannulation, leader pancreatitis. Hitch and ride technique is a relatively new method provided by us. So this technique can skip the guide wire grasping the pulling back step and the cannulation step, very easy, but require the dedicated catheter. I will show you the dedicated catheter like this. So make a slit on the tip of the catheter. So I make this special catheter by myself many times. So slit is so very useful to catch the guide wire and the insertion into the bile duct. I will show you the video. Sorry. Don't work. So I will show you the next video. So this is a EUS rendezvous in B1 reconstruction. So we select TDS and a very short position, but the puncture direction is relatively so discrepant. So and using the biliary manipulation. And during this step, we gradually change the scope angulation and adjust the guide wire to the papilla. And finally, very nicely guide wire in. And using the special catheter and attach to the guide wire and insert. And the second guide wire from the special catheter inserted into the bile duct. So I think this technique is very easy to get biliary access in a rendezvous technique. So this is Tokyo University's experience. Dr. Nakai summarized our data. So we experienced 30 cases of the EUS rendezvous from 22 original ERCP, from 8 from the outside hospital, failed the ERCP as the outside hospital. This is a result. So over the wire, 13 cases, guide wire loss 3. Change to the other type of the cannulation technique, 1. Finally, 12 cases. Along the wire, 4, but no success. And hitch and ride technique, so all procedures succeeded. I will show you the detail. So So guide wire travel in many over the wire, and conversion to the other method totally along the wire. Final biliary access completely in all procedure. And look, time from puncture to the cannulation. So shortest in the hit and line technique. So up to 24 minutes, 60. So I think hitch and line technique is very easy. This is our recent case in Juntendo University. So this case, the CBD stone and failed cannulation. So we punctured the distal CBD relatively thin, but succeeded. And look, so toward to the papilla, very short distance and a very good puncture direction, and easily insert the guide wire into the duodenum. And papilla in the diverticulum, they are very difficult to get biliary access. I will show you the cannulation video. So firstly, puncture the this CBD. Sometimes this step is difficult, relatively thin, but it is not so difficult, I think. So after the puncture, the injection of the contrast media to get a cholangiogram. So, and change the scope. So echo endoscope to the standard duodenoscope. This step, so very carefully. So, so I want to avoid the guide wire travel. So firstly, try to perform the along the wire technique. So very difficult to adjust the direction. But this is a special catheter, a hitch and line technique. So we can easily catch the guide wire and smoothly insert a catheter. And finally, second guide wire inserted into the bile duct and get biliary access. So from this video, so hitch and line technique is better than the along the wire technique. Okay, this is my conclusion. So EUS rendezvous technique is effective but still challenging method. Selection of scope position according to the patient status. So during the procedure, we can change the scope, the position. And the puncture direction was very important. And the guide wire manipulation was the most difficult step. And the guide wire grasping and the pulling back step was time consuming and the risk of guide wire loss. So I want to skip this step. And I recommend TDS, transduodenal short position, and the hitch and line technique. So I think this is a first line technique in a recent EUS rendezvous technique. Thank you very much for your kind attention. I finished my presentation.
So thank you, Isayama Sensei. So a wonderful lecture as usual. And any questions from the audience?
Raymond?
Yes.
I think there are quite a number of questions already, very popular questions. We don't have a lot of time. Maybe I think Professor Isayama, can you read the questions just below in the Q&A?
Q&A?
Okay, never mind. If you look down, there's a question from Dr. Laka.
Laka, okay.
Yes. Down there, starting from there, he said with the scope in the transduodenal long position, is it difficult to puncture using a 19-gauge needle? because the needle is quite stiff and the scope is in a long and angulated position. Okay?
Yes, so it is also very important thing. So recently we use Olympus needle. So Olympus needle is very flexible. So then I think I recommend you using the Olympus needle. It is more flexible than the other type of the needle. Other flexible needle is a Sonotip from the German company. It is also very flexible. And if you cannot get a very good puncture direction, I recommend using the hydraulic guide wire, so recommended by Vinay. So performing the transduodenal long position, we should overcome the many difficulties, actually. Thank you for your good question.
Okay, Dr. Yama, relating to this is because you're using a 19 gauge needle, the next question from Dr. Tarun, what if you lose access after the puncture? Because a 19 gauge is quite big, any risk of bowel leak?
So thank you very much for a good question. So puncture is not so difficult, I think. So the usually performing the EUS-FNA, so we can get biliary puncture even in a distal CBD. So, and bile leak, not so many, I think. So because this area, so duodenum and pancreas. So not so a large space between duodenum and the pancreas. And I didn't experience bile leak after the procedure. But usually I place a plastic stent after the every EUS rendezvous technique. So to avoid the bile leak, it is my answer.
Okay, so I think you have this very special hitch and ride catheter. One of the audience asked you about this thing. I think can we fashion a sphincterotomy and then cut below and then use it as a hitch and ride?
Yes. So I also try to make a special catheter with a sphincterotomy. It is also we can, but using the mesh. So but sometimes we should wear the glasses. At a small slit we can make. And before performing the EUS rendezvous, please try the slit attached to the guide wire. So if you easily to attach to the guide wire, you can perform the hitch and ride technique. Please try to make a catheter like me.
Okay, the question from Stephen Tong is how do you cut the catheter to make your special catheter? How do you cut it? You use a razor or how do you cut?
So the Caesar surgeon's mesh we use, and also a very thin cutter.
Okay. So I think there are quite a number of questions. We may be running out of time now. Raymond, what do you think? You want to go on or you want to?
I think like maybe we can save some questions after the next lecture because there will be some break time. I think if there are other questions, maybe we can use a little break time to entertain too. But maybe let's move on then.
Okay, good.
Okay, so so we have our next speaker. So so this is Professor Do-Yoon Park, and so our good friend from Korea, and he's going to share with us his experience on the technique and outcomes of EUS CDS. So thank you.
Can you hear me?
Yes, yes.
Yeah. So thanks to Professor Theo and others for inviting this fantastic program. So today I will talk about the technique and outcomes of EUS-CDS. As you can see, there are several kinds of the techniques for eusbd. As you can see, antegrade stenting or hepatic cholesterol or rendezvous, and sometimes we perform the colorectal duodenostomy, CDS. Let me show the advantage of the EUS-CDS. Most important advantage is this is no procedural pancreatitis because this is avoidance of a traumatic papillary manipulation, and is maybe ability to access the bile duct when the ampulla cannot be approached endoscopically in patient with the duodenal invasion or so other situation. And another advantage of CDS is stent does not traverse the length of malignant stricture. As you can see, maybe a prevention of the tumor ingrowth or overgrowth, maybe a prolonged stent patency may have. However, downside of CDS looks like reflux cholangitis in patient with duodenal invasion after placement of the EUS-CDS with plastic or metal stents. Most patients with failed ERCP may have a duodenal invasion or stricture, sometimes difficult in performing EUS-CDS and duodenal bulb, and some syndrome in EUS-CDS with LAMPS may have. Looks like an easier procedure, but narrow endoscopic window in duodenal bulb than EUS-HGS, because EUS-HGS may be performed freehand technique in performed B2 or B3 sometimes, is maybe a more wider endoscopic window for procedure. Now moving on the core techniques of EUS-CDS. Before puncture, looks like I think maybe CO2 insufflation may be important for the prevention of the double puncture in duodenal mucosa. You know, duodenal bulb is sometimes in patient with duodenal invasion obstruction a little bit very it's a tricky area because the puncture sometimes may be difficult, and there's a little bit not so insufficient insufflation of CO2. Maybe there is difficult for the puncture. Sometimes needle may be double puncture. Maybe mucosa may have some double puncture. Maybe there's some serious complication may have. And for 19-gauge needle, there is a possible chance of the very stiff one. I recommend before puncture, you can maybe advance of a needle tip. So you can see the endoscopic view first, then you can engagement of needle tip. First one may be important for before puncture, because as I mentioned, 19-gauge needle is a little bit difficult for the advance of the puncture sometimes. And during puncture, so I think maybe U shape or a long scope position for EUS-CDS with transmural stenting may be important. And sometimes you can check the fluoroscopic view of endoscopic scope position. I think maybe a full viewing echo endoscope better for EUS-CDS with color enhanced lamps, because prevention of the double mucosal puncture sometimes, or it's very difficult for the puncture with the 19-gauge needle in the flexible and long scope position in duodenal bulb. After puncture, 025 or 035 guide wire, you can choose. I think so for rendezvous technique, 025 is better. But transmural, you can choose the transmural technique. I think so, 035 is better, because you don't need any wide guide wire manipulation, just push the 035, a little bit more wide fistula tract than 025. I think it's maybe more easier for technique for the system, the technique for further fistula dilation in 0235 guide wire. Then you can choose the formula hurricane balloon dilator or fine tip catheter or one-step dilator or corollary tip dilator. And then you can choose the metal stent, partially curved, fully curved, or ramps. Or direct puncture with electrocautery enhanced ramps. At the time, I think the 6 millimeter is better than 10 millimeter because a possible deployment failure in 10 millimeter no stent expansion with stock is my personal experience sometimes. After puncture, fluoroscopic and endoscopic guide proximal stent deployment. Then endoscopic guided distal stent deployment is later. Sometimes a tubular stent may be over direction of tubular stent may have. At the time, you can push the scope with the anal side direction may have a prevention of the reflux cholangitis. For ramps, I think so with the coaxial double pigtail plus stent is better for direction of the stent or with ramps for allowed of the facilitation of the bile flow. Let me show EUS-CDS with transmural stenting. As you can see, scope position is a long scope position with a U shape and needle puncture with 19 gauge needle and 0-5 physical line I can frequently use. And there is a puncture of the EUS needle. Then we have an injection of the contrast. And as you can see, guide wire is a needle towards the hilum, and scope is a little bit easier, the fixed position than the EUS-guided hepatico-gastro. I usually perform the diesel is 7 French, metal tip, no fistula for the dilation. It's a one-step device for the EUS-CDS with transmural stenting. And then after then we have deployment of the EUS needle. As you can see, this endoscopic view, this is a metal tip with 7 French the original device for here is a fluoroscopic view and it is echoendoscopic view. You can see the stent as deployment here. And this one, we can see this endoscopic view for such like kind of the EICP endoscopic transpapillary stenting. This is another video. As you can see, the diameter is CBD is more 10 or 12 millimeter is better for the puncture of the EUS-guided collateral duodenostomy. As you can see, this U-shaped scope, position and long scope, and 0-5 guide wire. Then we have performed the original device with as like this one, and is diameter is the funnel type, is proximal one is 8 millimeter, is a later one is 6 millimeter. As you can see, for proximal stent deployment, we are used for the fluoroscopic and echoendoscopic view. And distal one, we can use the echoendoscopic view for the stent deployment. As you can see here, like it's very similar to the ESP with transmural transpapillary stenting. This is another case. This one is the EUS-guided collateral duodenostomy with oh sorry. Is marked CBD dilatation. There is after perform the EUS-guided puncture with the 19 gauge needle. We have is 0-5 guide wire is towards the hilum. Then we have a all-in-one device. We have push the push type of the standard deployment system here. As you can see, we can see the mechanical tip, metal tip of the here. Then deployment of stent. For this procedure, sometimes I prefer the 035 guide wire with 19 needle because sometimes it's very easier for the track dilation with just oriented device without any formula hurricane balloon, other system, other things. I prefer this more smaller introducer for prevention of the bioleak, because some kind of bioleak maybe have a possible chance of the during change of the accessory maybe possible in the EUS-CDS. Now moving on the outcome of the EUS-guided EUS-CDS. Recently, AGI published in the large cohort study. As you can see, there is the individual analysis or the adverse event. As you can see, there's a jaundice after procedure. It looks like spontaneous migration 1. Another is the visual related cholangitis. Interestingly, EUS CDS with ramps, their cohort may have a 4 cases of tumor obstruction, because as you know, CDS may have a advantage over the ERCP with transpapillary stenting in terms of the tumor overgrowth or ingrowth, because stenting may have far away from the tumor. However, ramps may have a tumor obstruction. Looks like ramps is just a location with the duodenum and the CBD, but sometimes tumor may overgrow with over the ramps in the inside of bioduct. Looks like I think maybe a tubular stent is much better than ramps in terms of the tumor overgrowth or ingrowth. In terms of the bioduct diameter, it looks like over the 15 millimeter is better for direct of electrically enhanced lamps without any EUS needle puncture or guide wire. I think this 50 millimeter is very important for the successful factor or predictive factor. I think for direct of EUS in electro enhanced ramps without any accessory such as guide wire or a 19 gauge needle. Let me show the classic EUS-CDS. Looks like a tubular stent with outcomes. Looks like stent dysfunction more up to the 66 millimeter over maybe 50% percent. Looks like adverse event is totally maybe is 22%. Technical success looks like is over the 90%. Outcome on EUS-CDS with ramps is looks like adverse events much lower than classic CDS. Stent dysfunction is a similar one. Technical success is okay, and looks like procedure time much better, I think. Well, let me show our data. It's the EUS-CDS versus HGS in subgroup analysis of randomized trial is for malignant distal obstruction. It looks like CDS HGS is very similar patient cohort and patient with duodenal invasion also, but clinical success is similar one, and procedure time is also similar. In terms of adverse event, CDS HGS is also similar. Reintervention is also very similar one. I think maybe a CDS HGS is very similar and is comparable efficacy in the patient with malignant distal obstruction. In terms of primary eusbd versus ERCP with duodenal invasion, looks like our data with meta-analysis is looks like eusbd is much better than ERCP in terms of the adverse event, especially as a procedure pancreatitis or others, may be much better. However, so in terms of primary CDS for the palliation of migrant biliary obstruction, there is a pros cons may have. Pros may be expert may have a similar technical and clinical success rate adverse event compared with the ERCP. And potential benefit for patients with borderline receptor pancreatic cancer, maybe undergoing neoadjuvant chemotherapy, maybe in terms of better stent patterns and lower rate procedural pancreatitis. However, looks like it's not so gained popularity and lack of dedicated device in some country or some center. I think some substantial learning curve may be required for beginner. And biolic and stent migration not completely resolved by conventional biliary metastent in EUSbd. And still, given a small patient number in previous clinical trial, primary use of EUSbd for migrant biliary biliary obstruction may be premature. Its take-home message is my take-home message is EUS-CDS may be safe and effective method for palliation of migrant biliary obstruction after failed ERCP. EUS-CDS with electric color enhanced lamps is gaining.
So I think the video is finished. We move on to the next session. I'd like to introduce the moderators, Professor Dongwan So, as well as Vinay. Professor So, can you introduce Vinay? Because he will be the next speaker. You need to unmute yourself first, Dongwan. Thank you.
Okay. Hello?
Hello.
Am I audible now?
Hello.
Good morning, everyone. I'm really excited to join this AEG group, EUS-guided biliary drainage webinar. This will be the second session. During the first session, we discussed the overview of EUS-guided biliary drainage and the guidelines. And we checked EUS-guided rendezvous and EUS-guided CDS. Now, during this session, we will discuss about EUS-guided antegrade stenting and hepatogastrostomy. The first speaker is Dr. Vinay Dhir. I think Vinay Dhir needs no introduction, especially in the field of EUS-guided biliary drainage area. He's the pioneer of EUS-guided biliary drainage. He still works in Mumbai, India, and he published a lot about EUS-guided biliary drainage. We are referencing his articles so many times when we talk about this area. Dr. Vinay, are you going to talk about EUS-guided antegrade stenting? Are you ready?
Hi, Dongwan. Good morning.
Good morning.
Good morning, everyone. Good morning, Lawrence, Anthony, Raymond, and all the people who are listening all around the world. I heard there are 900 plus participants from 60 countries, and this is really great. I'm so happy that the topic generates so much interest all around the world. And I must thank Anthony and the Asian EUS group for planning this elaborate single theme webinar. This is very close to my heart, and I hope everybody goes away after having some positive feelings about the technique and the results that we have got so far. So my topic today is antegrade stenting. So let me share my screen with you. Can you see my screen there?
Yes.
We'll talk about the technique and other things in the last 2 decades, and we are getting consistently good results with success rates in excess of 90%, and adverse events is probably as good as ERCP or maybe better for distal malignant obstruction. So we have got good studies, we have got good experience in the last 2 decades. Mark is here, he started it all, and Michel Kale will be speaking after me. He really took the technique forward. So we have actually all the stalwarts sitting here. I'm very happy with that. So the thing is, the advantage of EU. Yeah, with this new norm, audio can be a problem, Shannon. You have to speak very loud from your stomach.
Yes.
Okay. So have you heard the case history?
They are trying to remove the virus from the voice, so it is a little bit slow.
Okay. So basically now my scope, I'm using a linear echo endoscope, and I'm now in the duodenum.
Maybe Raymond can speak while Shannon does the procedure.
So now Shannon has her scope in the proximal duodenum.
We need to volume up the microphone volume.
Hello, can you hear us okay?
Okay, can you hear me better? Hello?
Okay. Can you hear us okay?
Okay, can you try, Shannon?
Okay. Can you hear?
Yes, we can hear you.
Okay, thank you. So now I'm in the duodenum. And you see the dilated CBD. So before the procedure, I actually pulled back I actually pulled back the PTBD. So the PTBD initially was in the distal bowel duct. So in order not to obstruct the puncture, I pulled back the PTBD and did a contrast study for this patient. So you can see now the CBD is right here. And incidentally, we actually found a portal vein thrombus, which was not seen on the PET-CT before.
Are you seeing some abnormal collaterals that obscuring your puncture, that may interfere with your puncture?
Actually, you see it's quite a lot of vessels nearby, but here, you can see that there is a vessel along with the CBD.
So, any tricks on
Shannon,
how to
can you trace down the portal vein thrombus and the tumor position?
Okay, so the CBD...
Is it started because of tumor infiltration, or what was the cause?
Oh, it's probably due to tumor infiltration. So you see here, this is the CBD. If you trace down, you see the tumor right here.
I can see some of it is associated with probably the tumor.
Yeah, so this is likely
a tumor
thrombus.
Yeah.
Oh, and at the same time, you can also...
we can see dilated CBD and portal vein flow, and also several collaterals. Now we can see the epinephrine surge from Shannon's body, and we can enjoy this.
And you can also see...
What are you planning? Putting in Axios?
So on EUS, you also see some ascites right here. So what is your opinion? So if the patient has ascites, do you think it's still safe for CDS?
Yeah, that's the CBD.
Yes.
Any preference on the diameter of the CBD that you would like to see before your puncture?
I think at least 1 centimeter, but now it seems I cannot find a puncture site that I can safely avoid the vessels around, the tumoral vessels.
Lots of collaterals.
Yeah.
That looks.
So
The axials, I think it should be okay.
Yeah.
Even if there's some.
okay.
Okay.
So for this
So for
patient,
this patient,
actually there are
actually
two
there are two
options that we
options
can
that
go
we can
for.
go for.
He failed
He failed
ERCP
ERCP before.
so either
either
we can
we
use
can
the
use the
PTBD
PTBD
for
for
rendezvous
rendezvous
ERCP, so
ERCP,
pass
so
the
pass
guide
the guide
wire
wire
through the
through the
PTBD and
PTBD
grasp it
and
with
grasp
an
it with an
ERCP,
ERCP,
or we can
we
go
can go
for
for
CDS.
CDS.
Raymond and Anthony, we lost the video.
Yes. Yes.
Okay, thanks.
Okay, thanks.
Subgo
So
gauge,
go
easy
gauge,
shot.
easy shot.
The EUS video is not on a big screen now, but the Shannon's voice is clearly audible.
I think someone is sharing the screen, so we will try to share back. So anyway, we can be prepared first.
So now
So
we're
now we're
measuring
measuring
the
the
CBD,
CBD,
and
and
it
it
measures.
measures.
Okay, so it
So it
measures
measures
10.3
10.3
millimeters.
millimeters.
So it would
So
be
it would
better
be
if
better
we can
if we can
inject
inject
more
more
to
to
dilate the
dilate the
CBD.
CBD.
So can we
So can
inject
we inject
more
more
to
to
the
the
PTBD?
PTBD?
Okay.
Rematch.
There is echoing, howling, so the engineers need to control this.
Oh, this is
Oh, this is Ceylan.
Oh, it's
So
okay.
it's okay.
Ceylan is
Ceylan
okay.
is okay.
So now you can see the CBD is getting more dilated because Raymond is injecting saline into the common bile duct.
Yes. But there is still echo. So
Okay, so
can you see the US
view?
yes, we can see EUS view clearly.
Okay.
Okay.
So I
I
think
think
there is a
there is
large
a
vessel
large
on this
vessel on
side.
this side.
So rotating the scope to this side.
Okay, the voice is very clear now, without any echo artifact.
Okay, can you hold the scope? So you can see on X-ray that the CBD is in front of where we are going to puncture. So, Raymond, do you agree that we should go forward?
I think so. Well, let's. I think those small vessels could be okay.
So
because of the voice issue, we did not hear your plan. What is your plan here? Are you going to use lamps or?
We're going to use a hot Axios.
Okay.
So you see now my scope is pointing upwards towards the hilum. Because today we're using the hot Axios, so puncturing a little bit closer to the hilum is still acceptable. But if the plan is to put in longitudinal biliary stent, probably puncturing more distally would be more favorable for stent deployment to avoid covering the hilar region. But because we're using the Axios, so that probably would be less of a problem. So now I have a 19 gauge EC shot, as you can see on the screen. So now I'm going to puncture the CBD. seems a little bit hard to puncture. Okay.
Looks like you're in.
So aspiration. So bowel is aspirated. And now contrast injection for cholangiogram.
Yes, we have a cholangiogram. Yes.
Okay. So we'll insert the guide wire. So in our center, we routinely use 025 curved tip. So this is the EUS-guided.
So Shannon, you are deploying the hot axios over the wire, not
yes.
doing a direct puncture.
No, for CP.
Any reason for that?
I just tend to prefer to be safer for bowel duct puncture.
Yeah.
For larger targets like gallbladder and pseudocyst, I do direct puncture. But for this, it's 11 millimeters and a big portal vein behind.
Right.
So I would certainly not like to double puncture the CBD for this. So now we're exchanging the needle for the wire. So it's important to keep the guide wire in the EUS view all the time. So the hot axios actually comes with a 6 millimeter, 8 millimeter, 10, and 15. So for this, I think I will use the 8 millimeter.
Okay.
What about you, Raymond?
I think 6 and 8 would be okay, but I think if you have a bigger duct, then obviously 8 is easier. But if you have a small duct, 6 may be easier. But I think this looks fine. I think. Yes. It looks like your axis of the wire looks favorable for the passage of the relatively stiff axials, right?
Yes. So I think maybe just now we skipped a part because the EUS video wasn't seen. So if I was going to puncture more at the distal CBD, my scope would be more in an up position, and the direction would be more pointing towards the ampulla. So it would be, the direction would be less favorable. That's why I pointed the scope on X-ray more towards the hilum. I always do this before I decide where I puncture because the direction is very important. The CBD size, usually it's 1 or 1.5 millimeter, 1.5 centimeter. So there is not a lot of space for you to push the stent in. So it is important to make sure that you have enough landing zone for the stent to go through.
Shannon, there is a question from Nikhil. You know, he was in Hong Kong with you. If you are using a longitudinal tubular stent, would you dilate this tract?
Would I what?
Dilate the tract before placing the stent.
Oh, yes. So
stent.
usually we use a 6 French cystotome and then a 4 millimeter hurricane balloon to dilate the tract. So now the hot axios is in. So you can see it on the EUS view. And the setting we're using is 120 period cut mode. So now I'm going to push in. So you see that it's easily in. Yeah. For CBD, the bowel duct wall is very thin. So it is important to stop the energy right after you puncture the CBD. Or else the portal vein is always behind, and there may be thermal injury to the posterior wall, causing a delayed bowel duct perforation. So now the distal flange is in. So we're going to deploy. So in EUS view, you see that it's pulling back.
Okay, very nice. Yeah.
Yes, excellent.
So this
Very
is
nice.
the distal flange deployed.
Okay.
So for us, we always use the deploy in channel method. So now I've pulled back the distal flange.
Okay.
And now deploying the proximal flange in the channel. And then we're going to change the scope back to the OGD view.
Yeah.
Okay. So gradually, I would put in a torque and push out the stent.
Oh, looks like it's out already. Huh? Okay. Some gush of bile.
Yes.
Yeah. All right. Very nice.
You can see deployed stent and also virus coming from the stent.
Wow.
Yes. So do you usually, would you recommend putting it a double pigtail for these cases?
Yes.
So you always put in a
case
double pigtail.
In this case, especially because there is some blood and a clot may form and block it. So it is better to place a double pigtail.
Okay. So usually what size of a pigtail do you use?
So we use the shortest that is available, a 6 centimeter double pigtail. Most of the times they tend to come out and hang down. But it makes us feel safer during the immediate post-stent period that if there is a problem, there is a biliary drainage always available through the stent.
Okay.
What length are you using? Are you putting a stent or are you leaving it like that?
Of course, I'm taking your recommendation. So we're going to put in a 10 French 3 centimeter double pigtail.
Yeah. Okay. Because sometimes these clots, they are temporary. It will go. The bleeding will stop very soon. But the clot formation can cause obstruction temporary. Michelle?
Yes.
Do you put a plastic stent always?
Yeah, so I've had a few cases where actually the axios will literally oppose itself against the wall of the bile duct.
Right,
and so
right.
just by placing a pigtail, you basically disimpact, you basically keep the axios away and doesn't allow it to suck against the wall, the opposite wall of the bile duct.
Right.
So for this reason, I think the puncturing direction is important. So as I mentioned, if you go for more distally, and when your scope is more in an U position, then your direction would be, the stent would be almost perpendicular to the common bile duct. But if you angulate it like this, then the stent is more likely to be at an angle to the CBD and less likely to cause the back wall to hit against the stent and causing obstruction.
And also, I think you had a very narrow window because of the collaterals. So you went more proximal.
So in this case, would anyone rather do a ERCP with rendezvous technique with the PTBD?
You know, Shannon, I love rendezvous, so don't ask me this question.
Even because PTBD is already inside, so
yes,
if the patient is not complaining discomfort, PTBD alone can be also useful. Or through the PTBD, we can inject some contrast oral saline and dilate the bile duct, and even we may try ERCP, standard ERCP.
I think
But if
currently
it fails, yeah.
TO is conducting a randomized control study comparing ERCP and a CDS for these malignant biliary obstruction. I think the underlying hypothesis is that the stent patency, because for CDS, we are inserting the stent away from the tumor, while for ERCP, the stent is within the tumor. So we're still waiting for the results for that study.
Yes, that would be a good study. But stent inside the stent is pushing the tumor away from the bile duct.
So why?
Can you make the fluoro big, please?
可唔可以要 X-ray 大啊？
Yeah.
Okay. Okay, so I think
These are very, very challenging cases. You know, the visibility and all those things. So great job.
they're okay 嘅，我哋 deploy 不如。because I think we punctured quite close to the hilum, so there isn't a lot of space for the gray catheter to pass through. So it's a bit tight.
But you started from long U position, and the scope position is quite stable. From the beginning until now, it is the same. This is very important and very advantageous.
So Shannon is demonstrating a stable scope position. This is tricky. Actually, we don't have much room to operate in the narrow duodenum here. So quite different from the stomach, actually. So some very fine movements and okay, so now we see the marking.
Yes.
Okay.
So you just have to be really slow and with patience.
Yes.
Okay.
And needs some good coordination between the assistant and the endoscopist here. So. Sometimes it's a little hard to disengage.
Yeah, the position. Yeah, the position is such that it may be difficult to.
Yes. Yeah. So any tricks from the panel when you encounter some restricted scope maneuvers due to the anatomy?
And you try to pull the scope a little bit back, make it a little straight, and then.
So I'm trying to rotate.
Okay.
So we all know that if you turn right, your scope goes down to D2. So now I'm trying to do a left torque for the whole scope. So gradually, hopefully it will come out. Because if we pull back the scope, I would lose the long loop position, and it would be less stable. So I usually try to rotate so that I don't suddenly fall out of the duodenum.
I think sometimes
Distal part of stent is already deployed, right?
Yes. I think what she's trying to do is to get the pigtail out of the channel. So
yes.
And she's trying to generate some space, but I think it's hard to do it in the duodenum. So.
Yes, because it's very small space.
Yes. Okay. Now, so now
it's good. Now you can push it out. Yeah.
Well, because the pusher at the out has been. It's
well,
we have all gone through this. Yes.
Yes. So very real life situation, right? So every case is different.
Yes. It's a great demonstration. Yes.
This is the beauty of life. Lecture always goes as planned. But life is different.
Yeah.
Masterly demonstration.
Yes. So and
Shannon, if you are not able to push it out, just pull it out and put another stent.
Yeah, I think the stent is deployed and the pusher is not working. So I'll use something else to push the pigtail out.
Yeah, maybe use a swing trotome or something.
So anything that is large enough to push it out.
Yeah.
So maybe I should have used an 8.5 French. Would have made it easier.
Yes. So Shannon, so maybe like we'll let you work on this a little bit, and then looks like Theo has something ready for us. So maybe we'll have a case presentation and come back to you later. Okay?
Okay.
Okay.
Shannon, fantastic. Great job.
Thank you, Dr.
So thank you, Shannon.
Thank you.
Yeah, good work. So we have a second case. So okay, we're gonna share the screen. Okay, let's see the. Okay, can you guys see the point here? So, okay, so this is the second case, and we have a 74-year-old gentleman. He has metastatic cancer of the pancreas with peritoneal metastases. So, CT scan from June showed a big mass at the head of the pancreas with biliary obstruction and also portal vein encasement. Unfortunately, ERCP in July failed due to duodenal obstruction. So here's the mass, here's the CT, and then there's a bigger mass causing duodenal obstruction. So today, our patient is here for EUS-guided HGS and duodenal stenting.
Hello. 轉過嚟啊，叫佢。Hello.
Hello.
Can you hear me?
Can we see Anthony's face?
Can you hear me? Hello.
Endoscopy room.
Can you hear me? Hello.
Yes, we can hear you.
You can hear me. Okay. So please show the endoscopic view. So this patient has a pancreatic cancer with double obstruction. I'm having a trial on comparing partially covered versus uncovered stent. So I already inserted a partially covered duodenal stent for this patient. So now I have a linear scope. You can see this is the aorta. My scope position is in the OGJ. So I'm going to just quickly show you the anatomy and the pathology. So this patient has quite a dilated PD. Dilated PD here. And then if I trace it down, this is the PD, and then towards here, you will see a big tumor mass around here. All right?
Yes.
And then if I go back up, so I'm going to go to the left lobe of the liver to assess the puncture site. So this is the left lobe. So if we perform an HGS, again, we usually try to target the segment 3 ducts. So this is the segment 3. Here, this is the segment 2 ducts. So this is segment 3, which is dilated nicely. The size is around 7 millimeters, 8, okay. And to perform ECS, I usually prefer to puncture the segment 3 ducts because there's less risk of mediastinitis. If you have to puncture, sometimes the segment 3 duct is not available, then you have no choice but to puncture the segment 2. But if you puncture the segment 2, then you need to be careful because you might end up with the stent in the esophagus, and you need to check your position frequently. Okay. So I'm using a 19 gauge flex, Boston Scientific flex needle. So this flex needle is made by with nitinol. So it is has a very good flexibility. So you can see a needle in a good position right now. So I'm going to start puncturing. So any suggestions, advice, comments? Would you do NT grade for this patient, Vinay?
Nice and easy for you, Anthony.
All right.
Always.
I'm going to move forward.
But in this case, no, Anthony, you have a duodenal stenosis. So I will probably agree with you. We'll do an HES.
Yeah. So my needle is in already. You can see bile aspirated.
Yes.
And then I want contrast.
So Anthony, is the patient flat or left lateral? Or,
I have the patient in prone position, ERCP position.
Prone, okay, okay.
Okay,俾啲西嚟我。西嚟。Whoops. Thank you. Okay. Say line, please. Thank you.
That's a very nice puncture.
Okay. So I'm going to inject some saline because the contrast may be quite sticky.
Yeah.
So we're going to put in a 025 BC guide wire. So
Vinay is always emphasizing the importance of thermohydrophilic guide wire manipulation, but you are using physical light. No problem with that?
I think most of the time with the 025 it has a very good maneuverability. So far so good.
No, it's a very good wire, Dongwon. The VisiGlide is an excellent wire. The only problem we have sometimes is the cautery. Because we use cystotome in almost all cases, sometimes I don't know why the cautery doesn't seem to work. That's the only issue. Otherwise, it's a great wire. See how easily Anthony has maneuvered it across.
All right. So yes. So VisiGlide 025 is very good for my own operator manipulation. So can we exchange the guide wire? Exchange.
Anthony, you are always manipulating the guide wire by yourself.
A lot of times, yes, because we do workshop every weekend. So we have to learn how to manipulate ourselves.
Okay.
It's a very good lesson, actually. If you know how to manipulate, it helps.
Yeah, it's a very good lesson. I agree. Yeah.
Yes, it's yeah.
So you can see my scope is in a very good position. The wire is very straight.
Excellent.
I'm going to change to a cystotome. 6 French to dilate, followed by a geoball. So as you know, recently the hot Spexis has become available. The hot Spexis has a cautery enhanced tip. I've tried it, it's very good. So the hot geoball is also underway. So right now we still need to change 1 or 2 instruments in between the stent deployment and also tract dilatation. I think if Doyon Park is here, he has a stent, which is called the DS stent from MI Tech. And that stent is also very good because it has a dilator attached to the front of the delivering system. So I think the world trend is towards a single step device.
I agree. If you have multiple steps on the same procedure, there is more risk of biliary and more risk of failure and complications. Better to have a single step device.
All right, so my sister told me it's here already, so I'm gonna burn my track.
Anthony, 6 French?
Sorry?
Is this a 6 French system?
6 French system. So very nicely, we're inside already.
Okay.
Okay, so can we have the open the stent? Great, okay. So I need to do it slowly because the other room is not ready yet.
You're going too fast, Theo. You're going too fast.
All right.
You are very fast, yeah.
Okay.
Please explain.
Okay, anyway, we should exchange.
Okay, so how about let's maybe talk about the stand you
Okay,
choose.
so I'm using the Taewong Geoball stent. So this is our usual stent. It's 10 centimeters times 8 millimeters in diameter. So it's a quarter uncovered. So the uncovered end is in the hepatic duct, and the cover end is bridging the stomach and the liver. So
70-30, huh?
Sorry?
70-30 cover and
yeah, 70-30. So I think for HGS, the most worrying part or the most stressful part is the stent deployment. So just now you can see all the puncture and dilatation is relatively straightforward. But with stent deployment, when you first start to do the procedure, because a lot of times you can't see the stent position very well. And when you deploy the proximal flange, also you need to be familiar with deploying in the channel technique. So let's change the stent.
Do our exchange. Theo, are you seeing any ascites in this patient?
There's a little bit of ascites, but not from the position where I punctured.
So if they have a lot of ascites, do you always have some ascites drainage before you do this procedure?
Yeah, it's a good point. We try to drain the ascites beforehand if there's a lot of fluid, because first of all, it can affect the healing of the fistula. Second of all, we can cause infection of the acidic fluid as well. So if there's a lot of acidic fluid, so we try to drain it. If you see some fluid on EUS, you can also try to drain it on EUS, but that's a bit cumbersome. But you can avoid a second procedure for the patient. If you don't have the geoball stent, I think people will use a fully covered stent as well. There's a slightly increased risk of migration. Some people would use a double pigtail to anchor that. But if you insert a double pigtail, be careful, because there is a small risk of causing the metal stent to dislodge. So in a newly created HGS, if you do too many interventions through the HGS, you need to be a bit more careful. So right now I'm inserting the stent. So usually for HGS I won't dilate the track. So it should go in. All right, good. And because this is in a very tension.
Yeah.
Very tension.
Yes. So very nice. So you're making a pretty sharp turn here. So any tricks?
Yeah, you need to be careful, because you can always dislodge yourself. So right now, I think I'm in a good position. We can start to deploy the stand. It should deploy inside. My landing site is okay, I think. So I'll probably land around this area. So can we start deploying? Why? Okay, good.
It's opening.
So the stent is going inwards. I'm going to pull the stent backwards a little bit. Try to readjust my position.
Yes. So Theo, how do you position that marker between the covered and uncovered portion in a suitable position here?
Yeah. So now you can see I'm adjusting my scope position, right? Just now it's a very long loop. Okay, so I'm going to pull back now. This is a marker for the uncovered to covered proportion. So I will adjust it slightly, and then we deploy the stent. Okay, deploy. Yeah. Okay, thank you. Okay, so now the stent opening is up to my scope channel. So I'm going to open the rest of the stent in the channel. Thank you. Okay, so now the stent is completely opened. Okay, I'm going to change to endoscope view. So this part is most difficult for beginners because you cannot see the stent very well. But because the stent is already opened, we can push the stent slightly out and then pull the scope a bit backwards. And then do the same thing, push the stent a bit out. So now you can see the stent a little bit in the 1 o'clock position. So now I'm going to pull back the scope again, push the stent out, pull back, push out. And then now you can see the stent very well. And then push out the stent. Okay. Okay, so now that stent is completely deployed.
Very nice. Very
So
Very nice.
this is the way that you can do the HCS. It has to be, it's usually you have to do it very controlledly. Can you keep the wire? And then it is my routine to do a cholangiogram after the HCS because there's always a small chance that the uncovered portion is outside the intrahepatic duct. So if the uncovered portion is outside the IHD, there can still be a leak in the liver parenchyma. So this takes another minute or so, but I think it's a good practice because HCS, the most worrying thing are leaks. And these patients are usually quite frail. So if they have any infection or leak, they usually would be more stormy. Okay, can we have the cystotom?
Anthony,
Yes.
when you start the deployment of stent,
I'm sorry, say again.
you inserted the bare part of stent deep into the angulated intrahepatic duct.
Yeah.
So it was quite a big safety margin.
Yeah. Yeah. So I think it depends on the patient as well. So sometimes the anatomy doesn't allow you to insert it so deeply. There is a small risk that the stent can cause obstruction of the peripheral ducts if you insert it so deeply. But in general, I think these segmental cholangitis can be treated with antibiotics and rarely need additional drainage. This stent is 8 millimeters in diameter, so it's okay. I'm inserting my cystotom now. Okay, why? Okay, okay, so okay, okay, no, okay, 唔使啦，唔使氣啦，
Okay.
翻返。So I'm going to inject some contrast. 撳住先，撳住先，撳住先。So hopefully it works. Okay, so it seems like there's no leak. Okay, so I'm happy with this. So any questions?
Leo, nice case. It's Lazaro.
Hi.
Question, do you use a traumatic needle?
Access needle, yeah. So access needle was designed to avoid shearing of the wire. But from my experience, shearing still occurs with the access needle. So I'm not a big fan of the needle. And for HCS, it's tricky to use the access needle because sometimes you don't go into the duct immediately, and sometimes you have to adjust the position of the needle. So if that happens, then you would need to reinsert the stylet. And because the needle is quite stiff as well, so sometimes that's very difficult. So I don't usually use access needle.
Okay, thank you.
Okay, so I think there's one more case. We only have 5 minutes or 10 minutes or so. So I think Raymond, are you ready to present?
Okay, so we are back here. Okay, can you hear us? So we're gonna have a presentation here. So this is a 69-year-old gentleman. And again, this is a case of cancer of the pancreas, status post, web post operation in April 2019. He has recurrence since this year, some tissue near the portal and different mat. So he developed apron limb obstruction in May, and EUS-guided apron limb drainage was performed, but apparently there's also bowel duct obstruction, so PDBD was inserted. So here is the cholangiogram of him by the PDBD, and you also can see the axials addressing the issue of the apron limb obstruction. So today we're going to attempt ERCP through this apron limb and plus or minus EUS-guided biliary drainage.
Raymond, we heard the case history. Can you go to the endoscopy room?
Okay, so hello.
Hello?
So Shannon is on air now.
Okay. Can you briefly summarize what happened with the previous case?
So this case had a history of pancreatic cancer with web post operation.
No, the previous case.
Previous case, or your case?
We put in the pigtail successfully. Yes.
Okay, thank you. Please go on.
So this case had a web post operation before for pancreatic cancer, and that was a recurrence causing apron limb obstruction. And a few weeks ago, I put in a hot axial for apron limb drainage. So you can see here on OGD, there's a bit of a buried bumper. So the stent is actually a little bit buried within the gastric mucosa. The patient subsequently had a PTBD also because of biliary obstruction. Do you see the X-ray view? So
a small X-ray view now, yes.
So it's only X-ray view.
Yes.
Can we see both the endoscopic and X-ray view? So I tried to inject some contrast through the PTBD. So now my scope is through right through the axial stent, but there is actually some tumor in front of the stent, so my scope cannot pass into the apron limb.
Okay.
So now I'm still quite far away from the bowel duct. So yes, what would you do, Professor Isayama?
Professor Isayama, are you there?
So, Shawn, what would you do?
Using the guide wire. How about using the guide wire?
Okay. So we try to use the guide wire through the PTBD and see if I can catch it on this end. So. So they may not be able to hear. So Theo is asking if Dr. Vinay has any suggestions.
So I would like to see, Shannon, what is the EUS picture there? What is happening in the liver?
Vinay wants to see the EUS picture.
Dilated?
Because I'm now using a 2T scope. Because initially we were planning to go through the stent and just attenuate the bile duct from below.
Okay.
So now we're trying to catch the guide wire from above. So Theo is now manipulating the guide wire. Very tight picture. So Theo said he thinks he can't go through. It's actually an HJ.
It's tough. It's tough.
It's quite stuck.
Yes, it's a very tight narrowing.
So would you do HGS, Vinay, for this
That
case?
would be my, I would look at the EUS because I think going through the axios is going to take a very long time because it looks very tough stricture. Probably the easiest way would be to access the left hepatic duct and place a stent there.
So it probably won't be very easy because the IC is not very dilated.
Yeah, it's going to, you won't get easy cases, Shannon. It's a very good case. So luckily you have a PTBD, so I think that might help you.
Anthony, are you going to do HGS? I think we already observed the technique of HGS live before, so it may be overlapped, and the time is already past 2. We cannot hear your voice clearly.
You mean now?
Yes.
Yeah, so I think it's okay for us to conclude this live session. Thank you very much for your comments. We still have some sponsors to show during lunchtime. They have some message for us. Any last questions, comments?
I think this is a wonderful setup, composing with the didactic lectures and also including live demonstration. As we have seen this live demonstration, live case always have variability, and we can learn from those variations. So I think it was a wonderful setup and a wonderful meeting. I have no further comments. Binay?
Anthony, fantastic. Great cases. I would have loved to see the third case actually, but.
So thank you very much.
Great cases. Fantastic.
I think Flora will share a screen and we will come back after lunch. Thank you.
Okay.
Fantastic.
Thank you.
Great.
Bye-bye.
Thank you.